I request Dr. Seema Kashyap to start with her presentation.
Good afternoon, everybody. I'll be talking on pediatric orbital lesions. Now, pediatric orbital tumors are rare. The differential diagnosis is very challenging, and because most of them are just small, malignant, small round blue cell tumors, and so you need a wide immunohistochemistry panel for a confirmatory diagnosis. And the core biopsies are so tiny. Again, the IHC is very difficult. It's very challenging, and genetic analysis also. So this was a 7-year-old child with a right orbital lesion since birth, which was gradually increasing in size. So CT scan shows a large mass, as you can see, with some cystic and solid areas, and an ectopic tooth within it. No eyeball was seen, and a lid-sparing orbital exentration was done, and the tumor was excised. And as you can see, this is the fleshy tumor which we got. And coming on to histopathology, you can see that there's a stratified squamous epithelium, and numerous hair follicles were seen representing the ectodermal layer. There was this cartilage, lamellar bone, bone marrow with bone marrow elements, intestinal epithelial lining along representing structures from the endoderm. So this was a mature orbital teratoma with an ectopic tooth in a primary anophthalmic socket, which is very rare entity. Another child, 6-year-old, who had proptosis of the left eye since 2.5 years, which is gradually progressing in size. As you can see, in September, this was the proptosis, and it progressed to this size within 6 months. So the CT picture, you can see that there's a large extracorneal mass in the left supratemporal orbit. So at this point, the clinicians had a differential diagnosis of an abscess, but the points against were no fever, schwannoma with cystic degeneration, solitary fibrous tumor. So when the mass came to us, these are the sections that we got. This was a tumor where there were multiple elements. This is the glandular element, that is gland-like arrangement was seen with tumor cells, hyperchromatic nuclei. And also we had the squamoid differentiation in a fibrotic stroma, along with mucin secreting cells, and AB pass was positive for mucin. So this was a mucoepidermoid carcinoma, which is very rare in the lacrimal gland, and even so rare in the pediatric age group. Usually they are cystic, and in this particular case, the long duration of symptoms, age of presentation, radiological picture was actually misleading, which was a surprise for the clinician. This was a 7-year-old child with proptosis, and on the CT also you can see the large mass filling up this orbit. In addition, the child had swelling of the right foot and right inguinal lymph node swelling. So we decided to do FNAC, and FNAC you can see in the papinicular stain, the PAP stain. It was a malignant round cell tumor. Same is seen in the MGG or May-Grindwald Giemsa stain. They are irregular hyperchromatic nuclei. We had some material left, so we prepared a cell block. Again, it showed a round cell tumor with areas of necrosis. And we resorted to immunohistochemistry. Desmin, NSC, MPO, all were negative, ruling out a rhabdomyosarcoma, granulocytic sarcoma. But IHC for MYC2 was positive. So MYC2 is positive in PNETs. So this mass was excised, the entire mass, and in the biopsy, in the sections also we saw a round cell tumor with numerous mitotic figures. Again, MYC2 was positive and PAS was negative. So this was a primary primitive neuroectodermal tumor of the right foot with metastasis to the left orbit. Another child with proptosis, and you can see the proptosis is so huge, it is just pushing down the eyeball. And in the histopathology, it was a malignant round cell tumor. So we resorted to PAS stain. PAS was positive in these cells along with MYC2. Now in such a case, when MYC2 is positive in PNET, and when PAS is also positive, it's a Ewing sarcoma, the same group of tumors, but this was Ewing's. And on systemic examination, this patient had a mass in the pelvis. So this was basically an Ewing sarcoma pelvis which was metastatic to the orbit. This was an 8 months old child, gradually progressive proptosis of the left eye since 1 month with decreased extraocular movements. Congestion was there, tender to touch. And on radiological examination, you can see a well-defined round to oval hyperdense lesion in the intracorneal and the corneal region of the left orbit. And on non-contrast CT, the diagnosis was query orbital hemangioma, query RMS. Again on USG, the diagnosis was query hemangioma. This was the mass which we got, a fleshy looking mass. And sections showed a round cell tumor again, this time again. It was a monomorphic round cell tumor with mitotic figures. There were some areas which showed vacuolated cells. In the lower picture, you can see numerous mitotic figures, vacuolated cells. So this was definitely a malignant tumor. And so differential diagnosis for us, the pathologists, now this time was an atypical Ewing, myeloid sarcoma or sarcoma with BCOR genetic alterations, which is a very new entity. So we resorted to immunohistochemistry. INI1 was positive, diffusely positive, SAT-B2 was positive, and BCOR was also diffusely positive. So we resorted to genetic analysis. FISH was done, fluorescent in situ hybridization was done, which showed the BCOR CCNB3 fusion. So this confirmed our diagnosis of sarcoma with BCOR genetic alterations. There are many alterations which can be seen, BCOR CCNB3 sarcoma or BCOR ITD sarcoma, which is more common, but in our case it was BCOR CCNB3 sarcoma, which shows round cell tumor. These are very rare aggressive tumors with a poor prognosis, hence an early diagnosis is required. An excision of this tumor has a good remission rate. Metastasis commonly to the lung. 5-year survival is about 72 to 80%. And this is the picture of the patient after chemotherapy. The patient responded very well to chemotherapy. So these are rare orbital tumors which should be kept in mind in the differential diagnosis, both for the pathologists as well as for the clinicians. Thank you.
Really come to know so many new findings. We'll go from the beginning.
Yeah.
Any questions from the audience?
How often do you use IHC as a routine?
Routinely we use IHC. We have to resort to IHC. Yes, all malignant.
Is there a first panel to do, and then look at the clonality and then look at
No. We first do see the morphology, the history, everything into account, and then accordingly decide whether it's a lymphoma-like thing or it's a RB-like thing, or so accordingly we decide the panel. We can't do everything together. So according to the morphology, we resort to the immunohistochemistry panel.
Okay, then.